You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. This is the second in a three-part series on palliative and end-of-life care. In this episode, we're going to be speaking about the last year of life. So in the previous episode, we explored what end-of-life care truly means and discussed its significance in the final 12 months of life. But as we learned, predicting this timeline is incredibly challenging, particularly for ambulance clinicians who may only encounter a patient in a critical moment without full awareness of their prior journey. So in this episode, we're going to delve deeper into what that last year of life looks like, especially from a pre-hospital perspective. So we're going to explore the challenges ambulance clinicians face when making urgent decisions, and indeed how they can be guided by existing documentation. We're also going to discuss the power of shared decision-making, also balancing specialist versus generalist palliative care needs. We're also going to look at the NHS Long Term Plan and key initiatives to improve care coordination. So finally, we're going to look at some of the barriers to effective advanced care planning, whether they're cultural, systemic, or indeed logistical challenges. And we're also going to consider what can be done to support ambulance clinicians in delivering the best care possible in these moments of uncertainty. To do this, I'm joined by Rowena Rickson and Natalie Nabunya. And what we're going to do is just get a brief intro and then we'll crack on with the episode. So Natalie, could I come to you first? Could I just get a brief bio for you, just a bit of a background?
Yeah, so my name is Natalie Nabunya. I work as a clinical nurse specialist now, part-time with the London Ambulance Service. My background is in general adult nursing. I've worked in hospital-based initially, working with elderly care patients, but in sort of the last couple of years have been a clinical nurse specialist within a palliative care team, where I also work part-time. I have worked both in a hospital setting, but more recently within a community setting as a clinical nurse specialist in palliative care.
Fantastic. And Marina, to yourself.
Yeah, my name's Rowena Rickson. I'm a paramedic, an operational paramedic with London Ambulance Service. I've kind of developed a special interest, I guess, in palliative and end-of-life care over a number of years. Was lucky enough to join the Macmillan end-of-life care team at LAS on a secondment last year, and I'm now a permanent member of the team alongside Natalie and Jodie and Karina, who I understand you've met before. So yeah, we're just a small part-time team, but flying the flag and doing everything we can to kind of try and improve and develop that area of care.
Fantastic, absolutely. And we really explored in the last episode just narrowing the gap actually within education and confidence, improving confidence, I think, on the ground. And absolutely, that's what you guys are doing, is really improving confidence in those really challenging cases, actually, end-of-life care cases. So let's just look at expanding on what we picked up on episode 1, which really was around the end of this, the final 12 months of life. And I wondered if you could just maybe expand on this. Natalie, I'll come to you first, and then Marina, get your thoughts on just this last 12 months and anything you can add from your perspective when ambulance clinicians meet patients in the last 12 months of life.
I think we should initially start by sort of thinking of what the last year of life likely looks like for somebody. And I think we need to remember everyone's individual, and this is by no means a prognostic factor in terms of what we're seeing. I think things will take their course of time, and we can't necessarily predict when somebody is entering the last year of their life, or at the end of their life sometimes. But I think things that we tend to normally see, I think I'd keep it at a more basic level within sort of palliative care or in a community setting, is just a general decline in somebody's health. That could be as a result of their underlying condition, likely cancer that's progressing, or their dementia is significantly worsening. So we will see things like worsening symptoms, but we also see things more from a practical sense that we take into account. Are they able to do the things that they were able to do last month? For example, can they dress themselves? Can they wash themselves? Are they needing more assistance with a lot of these things? And you can progressively see that happening over a period of time. Other factors we take into consideration is disinterest in things, in food, in sort of family life or things that they previously enjoyed, they might not enjoy it anymore. You might find that they're sleeping more often, for example. And as a palliative care nurse, that will tell me that things are starting to change. I think where the difficulty lies for the London Ambulance Services, they won't have that sort of background information that a palliative care nurse would have, or a GP service would have, or the district nurse, for example. They wouldn't have seen that patient trajectory over a period of time. And for them, that's where it can be quite difficult to predict whether what they're seeing is something that's acute and sudden, or, is this part and parcel of something that's been happening for a period of time. I think probably Rowena can pick this up for me, sort of from her perspective as a paramedic, in terms of when she attends somebody who probably is in the last year of their life, but for her can be quite a difficult scenario to unpick.
Yeah, I completely agree. I think it's really challenging for us as ambulance clinicians. We tend to sort of parachute into these situations, and we have to sort of make what I would term kind of a cold assessment. We don't know anything about this person. We don't know anything about their baseline. We have to establish all that, and we have to establish that really rapidly. And I think that can prove incredibly challenging, because obviously what we see is in that immediate moment. And I think we rely really heavily, once we've done all those kind of immediate assessments, we rely very heavily on other healthcare professionals' documentation about that patient, which is why the change to using the iPads, getting access to all of those tools like the National Care Record Service, London Care Record, and the Universal Care Plan has been, I think, game-changing for our ability to appropriately assess and treat this patient group in particular. I think it's really helpful for multiple patient groups, but particularly this one, because we can read what the GP thinks, or their last sort of set of observations, even with the GP. We can read what the specialist teams have got to say about these patients. We can read discharge letters. And I think as generalist practitioners, we rely so heavily on the specialists like Natalie, who've written this documentation. And I just don't want people to underestimate how helpful that can be in supporting those decisions on scene, because we drop in out of nowhere, and we've got a really short space of time to assess these patients and to treat them appropriately. And I think that's really important.
Yeah, absolutely. And could I get you to both speak to, and maybe Rowena first, to the surprise question?
Yeah, of course. I know you spoke in the previous episode about the SPICT tool and how valuable that is. And the surprise question sits more within the gold standards framework, the prognostic indicator guidance, which London Ambulance Service don't use so much. We tend to advise using the SPICT. But I think the simplicity of the surprise question, for me, is wonderful. And I think we need to remember that we're not prognosticating that this patient is going to die in 12 months or within 12 months. It's about asking yourself that question: would I be surprised if this patient were to die within 12 months? And it just opens up your thinking to a new kind of narrative, to consider what that patient needs, what's appropriate for that patient. Have they even been flagged by anybody else? I think as ambulance clinicians, we go to a lot of the sort of frail elderly patients who've just dropped off the radar of every other service. And actually, we are often the first clinicians to note and observe that patient might be in the last 12 months of life. So it is absolutely our responsibility to flag that patient to their GP, to the hospital, whoever it might be. And I think that surprise question just gives you that little light bulb moment of, do I need to think about this patient in that way? And I think we're really afraid of that, because I think we worry that by saying, actually, no, I wouldn't be surprised, we are sort of consigning that patient to their death. And we're absolutely not. We're actually supporting that patient better. So for me, it's a really simple question to ask that leads you into using the SPICT, all of the other kind of little indicators, and finding that evidence that backs up that sort of, I want to say, gut instinct almost, that actually you think that patient might be coming towards the end of their life. And I think its beauty is in its simplicity, and I think it's just about guiding your thinking.
So let's pivot slightly and look at really the power of shared decision making and just how decision making can be so challenging on scene. Could I get to this is something I'm guilty of as well, actually, is sometimes not sharing decisions when retrospectively actually it eases the burden of responsibility, and it also eases the burden of actually situation awareness when you've got someone else who's maybe stepped back from the scene to help you think in a different way and consider information that you may not have considered. Natalie, could I come to you first and really get you to speak to just this MDT approach, this multidisciplinary team approach, and just getting this semblance of shared decision making?
Yeah, I mean, I think from a community perspective, shared decision making is vital. There's many, sort of influence the patient, or rather teams the patient will get to know while they're being cared for at home, for example, or be it in a nursing home. I think we need to remember the community services that are all available and all have an impact with this patient and all have something to contribute towards this patient's individualized care plan. And I think the importance of shared decision making is to make sure that everyone's on the same page about a patient, what their care plans are. And I think especially when we're dealing with teams that are very responsive, like London Ambulance Service, for example, I think it's very important that those decisions that have been made is known to them so that they can better support and manage these patients when they are called out to see them. And I think just also that sort of interaction with GP practices, for example, just making sure that we're all on the same page is absolutely vital to not only, support this patient group, but also to promote, I guess, our working together and sort of strengthen those relationships amongst ourselves as practitioners. So I think in terms of shared decision making, it's one of the vital aspects for all of us, for all practitioners in a patient's care.
Yeah, indeed. Absolutely. I think it's absolutely vital, actually, especially when the complexity increases and getting that feedback is essential. Rowena, could I get you to speak to maybe just the interplay between specialist and generalist palliative care? Maybe when a patient isn't dying immediately, there is an interplay of where to go for specialist help versus generalist help. Could I get you to sort of speak to that interplay and where that comes in?
Yeah, I think that's something that we're not always very clear on as ambulance clinicians. I think it's sometimes really challenging to identify what that patient needs, and I think certainly earlier on in my career I didn't really understand the difference between the two, and actually many patients who are in the last year of their life don't need specialist palliative care input, if ever. And I think it's identifying which avenue is appropriate in that moment, and I think that's really difficult. And I think it just comes back to sharing those decisions, and we need to remember as ambulance clinicians that there are experts and they are on the end of the phone, and they not only do they know that patient very possibly a significant amount better than we do, they also know the sort of disease etiology, the disease trajectories a lot better than we do. We're jack of all trades as ambulance people, and we shouldn't expect ourselves to just know how to deal with all these individualized cases. Like Natalie said at the beginning, these are unique patients and they have unique needs, and we need to get the experts involved in sharing those decisions, and often they're quite big scary decisions, aren't they? So I think not underestimating the power of those shared decisions, and if you call the specialist and they don't need a specialist, then they'll guide you towards going back to generalist and going back to the GP. And it's just about opening up that dialogue and getting that input from those other teams, whether that's specialist or generalist, I think.
And I think I'll probably also come in just, off the back of Rowena, and just to highlight, thinking about episode 1, where we talked about who the palliative care patients are, sort of taking that description, not all of them will have symptoms as a result of their underlying condition, and not a lot of them will have complexity in terms of how to manage them. And sometimes just the GP supporting these patients, but recognizing that they're still palliative should suffice. I think where specialist teams get involved is where it's more complexity involved. People could be receiving, for example, if I had to give you a patient with cancer who was on palliative chemotherapy, so it life limiting, but trying to manage symptoms, but developed worsening symptoms as a result of their treatment or just their condition deteriorating, and the GP felt that this was something that they couldn't quite manage or on a more regular basis as a palliative care team would. That's probably the patients we would get involved with. And there have been occasions where we have been involved very briefly with a patient group and discharged because their symptoms stabilized, and we just put plans in place and we step back and allow sort of the generous palliative care to take over from that perspective. So it's just to give you a bit of what the differences might be with why specialist teams would get involved. I think just to add, there's more complexity there.
No, indeed. Could I get you to speak to both, if possible, just how this aligns to potentially sort of NHS long-term plans and ambitions to really coordinate care throughout the community, so that there is this, like you said, this interplay between consultation with GP and all specialist teams to make the right decision in that trajectory and that alignment to maybe more national guidance. Natalie, could I come to yourself?
Yeah. I think over the course of the years, we've recognized that people are not dying where they want to die and are not receiving end-of-life care that they would have ultimately have wanted. And so the ambitions framework, I believe Karina sort of delved into it slightly, has a few points on there, all quite vital. But I think maybe for the purpose of this discussion, the cares coordinated part is probably the one that we're really looking at. I think this feeds back into what we've talked about shared decision making. And it's all about ensuring that the individual is at the center of the care that they're receiving. It's all about what do they need? What do they want? How can we deliver that care? And so we need to make sure that we're all on the same page about it. And this informs back into, the ambitions framework informs the NHS Long Term Plan in terms of making sure that we're getting it right for this patient group, because oftentimes they can be the people who are forgotten because it just feels like, oh, but they're dying, But no, I think we need to remember that the treatment you receive during your life in comparison with your death is as important. You need to have a good death as you had good treatment and a good life. So where we're coordinating our care, where we're being more communicative with each other, that's the bottom line once we've established these individualized care plans.
So just moving on slightly, and Rowena, I'll come to yourself actually, if that's okay, just around what can be done to support clinicians with their shared decision making in the last year of life. Could you give us some practical steps and tips?
Yeah, absolutely. I absolutely don't want to sound like I'm telling GPs and specialists how to do their job, but I can certainly give an insight on what it's like as a frontline pre-hospital clinician to, as I said earlier, parachute into that scene and try and unpick this potentially incredibly complex patient scene, etc. And I think there's some really key things that are massively beneficial, and it is all about that rainy day thinking. It's those advanced care plans being prepared in good time with that patient at the center of them, and it's essentially representing that patient's voice if someone like me comes in and they can't speak to me. And I think that's the heart of it. So in London, we're very lucky. We've got the Universal Care Plan, which is an online record. It's accessible to patients through their NHS app as well. So again, that's a huge step in involving that patient in their own care. They can see it. They know exactly what is documented about them. And those bits of information are massively key to us when we're making a decision at 2 o'clock in the morning as to what's the appropriate treatment for this patient. When you can't call a GP, you probably can't call a hospice. you're kind of on your own. And actually that documentation is massively important. And that hopefully will contain things like a CPR decision, whether that has been made. If it hasn't been made, maybe there's a really good reason why, but I need to know that at 2 o'clock in the morning as a paramedic in that situation. It's really helpful. It sounds really silly, but it's really helpful to know who did you have these conversations with, whether you're perhaps a GP, if you just had conversation with patient's son, but actually they've got 4 sons and the other son's here and they haven't talked to each other. So it sounds really silly, but just tell us who you've had that conversation with. It's not just about what conversations you've had, it's who knows, because that's so vital to us when we have no one else to speak to at 2 a.m. And I think I really appreciate that these are such difficult conversations to have, and I don't have them. People like Natalie have them, GPs, specialist teams. I can't imagine how challenging they are, but the detail is so important to us.
Could I get you to speak to, and Natalie, I'll come to you, just really around holistic assessment. I'm here in Germany and they call it Gestalt, or, the whole assessment, the whole person. You're not just maybe the symptomatology, but you're right, the pain management, the social circumstances, and just that whole assessment of the patient. And as you were saying before, the giving them the quality of dying throughout their trajectory. Could I get you to speak to that sort of holistic assessment?
Yeah. I think that's a bit part and parcel of my job, and it's a bit like, ooh, what exactly? How can I phrase it? I think we need to remember that an individual is not just a disease. We're not just looking at this is what they've got, and now we need to manage them just because we know they have a disease and they need a painkiller. I think we need to make sure that we're thinking about where are they living, how are they living, who are around them, who are supporting them. There's that sort of we tend to forget how impactful their next of kin, their significant others, and their family are for this patient. We need to think about sort of the psychological elements as well that could impact. Somebody could have physical pain that's just worsened by the psychological background of just being in pain, and that could just amplify a situation. So we need to recognize the other things that would be impacting on this person's life. Is there things like finances that we need to think about? It's the little things of our daily lives that we tend to forget when we come and see a palliative care patient. What's important to them? What did they enjoy? Who were they? We need to go back sort of into history and to understand the individual, and then obviously start thinking about, what do you want now? How can we support you? Making sure that we're taking into account how they're viewing things and how they want things to happen. And then obviously going into things like advanced care planning, starting to think about, recognizing sort of where they are and the trajectory of how things might go. And, it depends on the person. Sometimes they're not open to those conversations, and it's about building those relationships, but thinking about the future, how can we support you as things go along?
Yeah, absolutely. I totally agree with all that, actually. And you're right. I'm guilty, and certainly colleagues, of just seeing a disease rather than the whole person. Rowena, you said before about, capturing sometimes, we are the first clinicians, presbyteral clinicians, the first clinicians to really articulate and indeed, find patients which have slipped through the net in palliative or end of life care. Could I get you to speak to when nothing is in place, when you find there is no advanced care plan, or indeed there is no specialist team around patients? Could I get you to speak to sort of next steps, and indeed how we build that up for patients?
Yeah, absolutely. And I think that is something that is not infrequent, particularly with an aging population. I think it's going to become increasingly the case. And I think that's going to have huge impact for us. Obviously, if you encounter that sort of patient, you really just have to hope that it's between Monday and Friday and 9 till 5 when the GP is open, and you can start to have those conversations directly with that patient's GP. But actually, the out of hours are significantly longer than the in hours everywhere. So I think it's about going back to that patient and utilizing all of your best communication skills with that patient's family, significant other, whoever is there, potentially caregivers who knows that patient very, very well. And it's about starting to unravel what is important to them and just, I think, start to elicit those conversations. I think it's not perhaps entirely appropriate for pre-hospital clinicians to have those conversations in great detail because they are really long conversations. They're really hard conversations. And I don't know that patient. I've been there for 20 minutes. They don't know me. I'm not going to necessarily get all of those really honest, considered answers that someone like Natalie might get later. But I think it is just about identifying those patients and planting those seeds, if you will, in a really, I think the two words that spring to mind are really honest and really empathetic. And just starting those conversations and then making sure that you pass on that information really, really clearly, whatever your kind of local guidance is about out of hours referrals perhaps, or if you're going to take that patient to hospital, really highlighting those. And I think that comes down to massively good communication between yourself and the next healthcare professional, because that's when those bits of information are going to get lost. And that patient isn't necessarily going to know how to advocate for themselves. So I think giving a really robust handover, like we recommend the SBAR tool, and I think it's so valuable because it just gives you that structure, that backing to make sure you get all of that information in there and not let any little bits slip through the cracks. Otherwise that patient is going to, after all your hard work and all of those conversations begin, they're just going to slip through different cracks in a massively complex healthcare system. And documentation, it's not very exciting, but it's so key to passing these messages through. And I think again that comes back to how the leaps and bounds we've made with technology and the ability to share information, but actually you've got to write it down because someone else needs to be able to read those conversations you've started, those things that you've noticed. We're in an incredibly privileged position that we go into people's houses, they open their doors to us and they say, yes, of course you can look in my kitchen cupboards. Healthcare professionals in a hospital don't get to see that picture, and we do. And I think it's so key that we pass that information on so that other people get that on-scene vision of what we've seen, that actually your 90-year-old is not coping very well anymore and needs that review. And I think that's not to be underestimated.
Natalie, could I just get you to speak to just difficult decisions and difficult conversations, really more around difficult conversations with family members or indeed the patient themselves, actually, around advanced care planning discussions? Could I get you to speak to maybe, like Rowena said, these discussions may not have been initiated by the GP or others if they've fallen through the net, and actually, unfortunately, pre-hospital clinicians may be the ones to maybe start that dialogue or start that narrative. Could I get you to speak to sort of these difficult conversations and how we maybe initiate them and who with and how?
I think we don't go through life thinking about the end. And, somebody walking or coming into your house, such as myself, and starting to talk to you about death and dying and, trying to get you not necessarily to make a decision, but be part of a decision around your life can be quite intrusive and it can be quite scary. I think we need to remember that these are things that, it's not something that's routinely spoken about and can be quite frightening for different individuals. I think in terms of difficult conversations, it can come from a myriad of different factors. It could be the patient just not willing to engage. So you don't want to think about your end of life. And from a very human perspective, I understand that. It's not the most pleasant conversation to have. But then they're also family. Family don't want to talk about it. People have hope. People have spiritual their faith plays a significant role in this. They don't want to have these discussions because it's not up to us to have these conversations. But also culturally, it's something that might be shunned. Why are you talking about the end when the person's still here? So a lot of those things can impact on us making that decision or helping make that decision alongside the patient, or even having those conversations. I think where we as sort of pre-hospital community support, I think what we need to remember, especially in terms of London Ambulance Service, is that we can still highlight on the Universal Care Plan that these decisions haven't been made as yet, and why those discussions were quite difficult. And I think that will help the ambulance clinicians. I think if the decision hasn't been made as yet on the Universal Care Plan, I think it's important that we highlight that what's happened and why that decision has not been made. I think sometimes the power of the information can translate very differently when they already know, or rather when they find out that actually that they weren't happy about this conversation, etc. Sometimes that allows you to have a step in the door at the least, and build some form of rapport, because then they'll be like, okay, this information, people do have this information. So those are the barriers sometimes that we might be facing as palliative care teams or GPs when it comes to sort of thinking about having those difficult conversations. Do not resuscitate conversations tend to also be very difficult. I think I want to touch on this just because I want to highlight that sometimes TV shows have influenced a lot of the public in terms of what resuscitation is and what it looks like. And I think it paints a picture that's actually very false. And, when we think about out of hospital cardiac arrests and the success of that, it's definitely not a lot of our population coming to those numbers. And so there's a lot of challenges. There's a lot of pushback from family, from patients as well, saying, no, I think, they can just resuscitate me. And sometimes having a conversation about what CPR looks like, they can be very difficult, because sometimes you need to be very graphic to get your message across about why it would not be of benefit to them. I think we also need to remember, in a hospital setting and even in a community setting, do not resuscitate orders for the medics. It is part of their jobs, and we don't need family necessarily to sign any form about whether they want to be resuscitated. So we get that a lot, that I didn't sign the form, so it doesn't it doesn't apply. But it is a medical based decision, and that's another thing that we need to make sure that the public are aware of. But as part of a palliative care team, it's important to remember that we might not put this in place because of the amount of distress it has caused the family, and we need to think about what the future for the family might look like around if we were to put it in place, and an ambulance clinician showed up and did not resuscitate. We need to think about how the impact of that would look like for them in the future. So I think what we need to remember is that the individual is still important in these conversations, even though they can be medical based decisions. We need to make sure that they're aware and they're on board with it. Part of the other things that we talk about are treatment escalation plans, in terms of, does this individual want to go back into hospital, or what's the level of care that they're willing to have within the home setting? And it's equally making sure that we document those conversations, because again, that goes back to what Rowena was saying, is that if you tell me how I can support this patient, then it puts me in a better position. And if it means that you go back to hospital, fair enough. But if it means that we're supporting you at home, they can do as much as they can to make you comfortable until we get the other resources and services in place to manage you where you are.
So let's just double click on that really as we come into land on the conversation for this last year of life, because this is super important actually, from really navigating these conversations well. And Rowena, I'll come to you really about maybe sort of barriers that ambulance and or palliative care clinicians might encounter when using advanced care plans, and indeed having these discussions with families. Could I get you to maybe speak to the purpose of an advanced care planning, and maybe bringing families and the patient along on that journey, just to really see the benefit to this?
I think it's about remembering, again, don't want to sound like a broken record, but it's about putting that patient in the centre and remembering that ultimately it's about their wishes and their preferences. And for example, quite a lot of dementia patients find going into hospital exceptionally distressing. And actually, is that the right place of care for them? So having that documented, that someone's had that conversation about that patient is a really good jump off point. But I'm sure a lot of clinicians will have been in the scenario where a family member says, no, they have to go to hospital, they have to get IV antibiotics. But actually, what does that look like for that patient? What does that look like for that family? The realities versus the perceptions, I think, is a massively important conversation that, again, we are all responsible for having. We hear on the news about how overwhelmed hospitals are, but actually, do you understand the reality of putting a dementia patient on a bed in a corridor for potentially getting IV antibiotics? And I think just being incredibly honest about that conversation, because expectations and reality don't always align. And I think having those really honest conversations in a really kind way, in a really humane way, with everybody on scene, bringing that family along with you, because you need to have their support. You can't be kind of dictating. I think you need to have everyone's buy-in to go down whichever route you're going. I'm not saying you don't go to hospital. Sometimes you need to go to hospital, and that's absolutely the right thing to do, and we shouldn't be afraid of making that decision. But sometimes it isn't, and I think it's about weighing up all of those bits of information that you've gathered from all of those really important people, from specialists, from family, through the ACP, through those conversations, to hear that patient's voice, to really understand. But you've absolutely got to communicate, to take all of those people with you on that journey, and just be really honest. I think it always comes back to that level of honesty. And if you don't know, say you don't know. We don't have all the answers, and it's okay not to have all the answers, but just I think to be really honest about it.
So, Rowena, what would that look like for a dementia patient that maybe doesn't have capacity, and how would clinicians maybe navigate that?
So obviously, whatever's documented in the UCP is really central to that. But also we need to be thinking about making a best interest decision for that patient if they're no longer able to speak for themselves, if they've lost capacity. And that includes looking for those legal documents which would help to inform that decision. So a family member might have a lasting power of attorney or LPA. It's really important to establish that that's for health and not for finance, because obviously they are different. And a lot of family members say, yeah, I've got lasting power of attorney, but actually you find out it's for their loved one's mortgage and not for their health decisions. I won't get into too much minutiae of the legal sides of it, but it's really important to establish whether one exists and is valid. So you need to view it and ensure that it is valid. You've also got advanced decisions to refuse treatment, which are also legally binding documents, but they have to contain certain pieces of information in order to make them legally binding. So I think for clinicians, that's just take a breath, take a pause, don't rush that, because you have to be certain that that is all neatly ticked and squared away. I'm sure every trust like us will have guidance around how to establish the validity of those documents. And if either of those are in place, then that will really help guide your decision making, because that will allow those documents or that family member to essentially make decisions on behalf of that patient. They're not always in place, and I think that's when it becomes significantly more challenging, and we need to go back to that best interest decision. And that, again, comes back to that shared decision making. It comes back to finding out what is right for that patient, whether that's talking to the GP, the specialist teams, internal specialists who within ambulance trusts, and just coming back to what is right for that patient, putting that patient back in the centre of that decision and working out what the best wraparound care for that person is. And like I said, if that's go to hospital, then go to hospital. If it's not going to hospital, then that's okay too. And every single one of those decisions is going to be as unique to that patient as every other clinical decision that we should be making.
So just as we finish off, Natalie, I'll just ask this to you, and it really probably leads us into the next episode quite nicely around the dying patients, the patient which fundamentally is dying and in the last minutes of life. Could I get you to speak to, and Rowena, please feel free to chip in afterwards, around the reversibility, so say hypoglycemia, or indeed something which is reversible in that dying phase. How should we maybe approach those decisions around reversing things which are clearly within the wheelhouse, or indeed the capacity for a clinician? Could I get you just to speak to those tricky sort of ethical considerations, really?
Yeah, reversibility is also very challenging for us clinicians. They take form of things that are, sort of like opportunistic infections where there is treatment available. And I think sometimes it might be very hard to distinguish whether someone is starting to die or whether an opportunistic infection, or they're hypoglycemic, whether that's what's sort of really driving a lot of the change that you're noticing in the patient. I think we need to think and go back to, as Rowena says, what was the patient, what were their wishes, what did they want? Obviously, as a palliative care nurse, one of the first and foremost things, aside from individualizing that plan or thinking of the patient at the center of that decision, is what symptoms are they suffering from, and what can we alleviate now? And also just incorporating family into that decision, the GP or other services that might have been involved, that might be able to give us a bit more information around what are the next steps, what should we do? Should we manage this within a home setting? Do we think that actually this person is just starting to die? Or is this something that we really need to take a bit more seriously and either convey into hospital potentially or start treating aggressively? But we need to remember, would that be the most appropriate plan for this person? Or do we need to have a bit more frank and honest conversations that maybe this is something that's just part and parcel of the natural process of them starting to die? So reversibility remains something that's very challenging. The one thing that I think I will say, and also will help sort of the ambulance clinicians, is that it's important for palliative care teams to recognize what is likely a reversible condition, and to highlight that in the universal care plans. Specifically, if it's an infection, a UTI or a chest infection, this is what the management plan that they would foresee. And I think that would help clinicians, because just saying take to hospital for reversible causes, I don't think quite helps an ambulance clinician. I think we need to be a bit more descriptive in sort of what we're highlighting. Yeah,
I'd really strongly second that. I think the term reversible, take to hospital for anything reversible, well, anything's reversible, isn't it, if you drill down into it? And then you've got to get onto the really big question of, should it be, is it appropriate for that patient for whatever it is to be reversed? And I think it's really important to remember that that is not a decision to be made in isolation ever, because they're huge decisions. And I think for ambulance clinicians, most of us came into the job because we want to save life, to preserve life. And actually there's a huge shift from that survival focused care that is most of our work, to the provision of that supportive comfort care. So it's a huge brain shift for us. And I think involving others in those decisions, as we've said so many times in this last 30-45 minutes, it's just so important. And we just need to phone a friend, use all of those tools that we have available to us, and phone a friend, have a conversation, be honest, be empathetic.
I think it's fantastic, and that's absolutely fantastic, and I couldn't agree more, actually, Rowena. Listen, thank you both for the last 45 minutes. It's fantastic just to get your perspectives, your reflections, and indeed, really broke some really challenging topics, actually. So it's fantastic just to get your thoughts. And it leads us nicely into the last episode. And so we'll see the team again shortly for episode 3. But thank you both so much for the last 45 minutes.
Thank you.
Thanks for having us.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.